This program is brought to you by Emory University.
Good morning, everyone. Today's speaker is Dr. Gina Lundberg. Gina is a graduate of the Medical College of Georgia and did her cardiology fellowship training at Rush, and has been back in Atlanta, very active in the American Heart Association. She's been a real advocate for women's health. She is the clinical director for Emory's Women's Heart Center and assistant professor of medicine. Gina, welcome.
Well, thank you for having me, or I guess I signed up, so you're stuck with me is the reality of it. I know you all usually have highly scientific talks this morning, so this is going to be very pragmatic, very clinical. For those of you who take care of humans, particularly females, you may find it interesting. For those of you who take care of rats, if you have female rats, you may find it interesting, or you may just want to turn around and get out of here. I have no disclosures. All right, so we're basically going to go over what happens to your lipids at the time of menopause. We're going to talk about the primary and secondary trials with hormone replacement therapy. We're going to go over the NAMS, or North American Menopause Society recommendations. We're going to briefly remind ourselves of the 2011 update on the effectiveness-based guidelines for prevention of cardiovascular disease in women. We're going to talk about the new things, and then I'm going to give you a little case that kind of combines it all, a little real-life woman. So to get you thinking as we go through it, this is a 52-year-old female. She has a history of abnormal lipids and high blood pressure. She has impaired fasting glucose, and she's been trying to avoid medications, and she keeps saying, let me work on diet and exercise, I'll lose the weight, I'll do better. But alas, it is a year later, and she has had no success. Her primary care doctor is her gynecologist, and she has a lot of menopausal symptoms: poor sleep, hot flashes, moodiness, a lot of symptoms. And so she wants to know, is it safe for me to go on hormone therapy? These are some of her biometrics. She's got a BMI of 32.5. Her waist is 36.5 inches. Her blood pressure is 148/85. Her total cholesterol is 246. Her LDL is 183. Her HDL is 49. Her triglycerides are 144. Blood glucose, fasting blood glucose is 109. Her C-reactive protein is 0.8. When you calculate her in the American Heart ASCVD risk assessment, she has a 2.9% chance of having a cardiovascular event in the next 10 years. But because she's young, her lifetime risk is important, and it's 38.8%. Her hemoglobin A1C is 5.9. Her EKG is normal. She's had no complications with her previous pregnancies, and she has no primary relative with cardiovascular disease before the age of 65. So let's talk about menopause. I see we have a few women in the audience, so you men might need to know a little bit about this. The average age is 51 in America. Prematurity of medical interventions, such as having her ovaries removed, chemotherapy or radiation, anything that damages the ovaries, will put a woman into menopause early. And anytime she has impaired ovarian function, which can be multiple endocrine disorders. Every day, about 6,000 women reach menopause, and that's about 2 million per year, so it's very relevant in our practices. And because a woman lives now to the life expectancy of 80.5 years, she's going to spend about 30 years in menopause, postmenopausal state, and having to deal with these issues, so we need to know about it. So what happens to your lipids at menopause? Well, the PROCAM Munster heart study was a prospective study looking at cardiovascular risk in women. And significantly, from premenopause, premenopause and at menopause, there are statistically significant differences. Obviously, age, we were comparing 48 to 51-year-olds, but the BMI went up from 25.8 to 26.4. Cholesterol, total cholesterol increases from an average of 221 to 239. Triglycerides increase significantly, an average of from 88 to 99. LDL jumps from 143 to 158. HDL stays about the same at the time of menopause, and that's not statistically significant in this study. And then the total cholesterol to HDL ratio also increased. And there are other factors that are affected at menopause. Fibrinogen increases, There was no change in D-dimer, but factor 7C goes up, protein C goes up, plasminogen goes up, pi goes up, von Willebrand factor does not change, and CRP actually dropped a little. So what we see when we look at these graphs is this is LDL prior to menopause and then at the time of menopause, and there's the increase we saw. HDL actually starts dropping before menopause and then is fairly stable at the time of menopause. That's why we did not see a change. LDL starts going up before menopause and continues to go up. And triglycerides are fairly stable prior to menopause and then continue to escalate. So what we see in menopause is a lipid triad of higher triglycerides, higher LDL, and lower HDL. We see abnormalities in insulin that make a woman more insulin resistant or pre-diabetic. She has decreased insulin elimination, decreased insulin secretion, and hyperinsulinemia. And then the other clotting factors, we see changes in endothelial dysfunction. We see increased visceral fat. A lot of women refer to menopause as menabelly because they get a lot more fat around the waist. Increased uric acid. We see more women having gout after menopause. They have a decrease in sex hormone binding globulin, an increase in blood pressure, and an increase in pi. So let's review what estrogen does and then progestins. So in relationship to atherosclerosis, with estrogen we see decreased LDL oxidation, decreased LDL binding, we have an increase in blood pressure, we have a decrease in oxidation damage, a decrease in vascular smooth muscle proliferation, and decreased glucose tolerance. Whereas progestins have relatively no effect on the HDL, relatively no effect on blood pressure, but increased glucose tolerance. With thrombosis, estrogen actually increases coagulation factors and decreases platelet aggregation, whereas progestin increases coagulation factors but decreases platelet aggregation and decreases nitric oxide, which you know is important for vasodilatation. And the vasomotor side of things, estrogens increase nitric oxide, decrease endothelin, increase COX-2, decrease neuroendocrine response, and decrease vascular smooth muscle proliferation, whereas the progestins increase vasoconstriction and decrease nitric oxide. And then for our arrhythmia physicians in the audience, estrogens increase QT prolongation, but progestins decrease QT prolongation. And this can have an effect on their EP studies. So let's review the terminology a bit. So estrogen therapy is unopposed estrogen in a woman who has, systemically for women who do not have a uterus, so with someone who's had a hysterectomy, or it can be used in a low-dose transdermal or vaginal cream for symptoms, particularly dryness. Estrogen-progestin therapy. Progestogen is added to estrogen so that a woman does not get endometrial hyperplasia of her uterus, and it never should be used alone in a woman who has a uterus. And then bioidentical hormones. This is a phrase that you hear a lot, particularly with gynecologists who have compounding formulas, compounding pharmacies in their offices. And it's really sort of a scam, and even the North American Menopause Society says that. The bioidentical doesn't mean anything different. That there's two types. There's the FDA-approved ones, and then there's the ones that are compounded in pharmacies. And a lot of women are really into this, but it's not any safer and it's not any different. So all the observational studies led us to think that hormones would be beneficial to women after menopause. And this looks at people who ever used hormones or current users. And you can tell from these 40 observational studies that it suggested a protective effect with all of the data being on this side of the line. But what happened was when they looked at randomized controlled studies, we didn't see that anymore. So there's this reproductive hormone paradox. The observational studies suggested that there would be a lower risk in women if they used hormones after menopause, based on the fact that before menopause, women have lower risk compared to men. And yet the randomized trials did not show that. So is there a difference in how the hormones affect a woman who has not developed atherosclerosis or in a woman who already has atherosclerosis. And so these are the changes in early atherogenesis or no atherosclerosis versus when a woman has established atherosclerosis. And there are some beneficial effects of hormone therapy in a woman who does not have atherosclerosis. As I said, increased vasodilatation, less inflammation, more nitric oxide. But once she has atherosclerosis, this alters the biology of the endothelial function. And now there's decreased vasodilatation and increased inflammatory activation and increased plaque instability. So there is a difference on the artery depending if there's atherosclerosis present. So let me review the hormone trials for you. And I'm going to go through this fairly quickly, and I'm not going to go through every study. So there's a lot of secondary prevention trials, and so we're very confident that a woman who already has atherosclerosis does not benefit from hormones. I'm going to go through the HERS trial for you, and then of course we have to go through the Women's Health Initiative. So the heart and estrogen-progestin replacement study is the HERS trial, and you all have probably heard a lot about it because Dr. Wenger was involved. It's a secondary prevention trial to study hormone therapy in women who had documented coronary heart disease. It was a prospective randomized placebo-controlled trial. There were 2,763 women with coronary disease, and this was evidenced by previous MI, CABG, angioplasty, or an angiographic study that showed a greater than 50% occlusion of the coronary arteries. One of the faults with the program, with the trial, is that it is an average age of 67, and it's predominantly white women. So this is your little old white lady study. And it was followed over 4 years. The primary outcome was non-fatal MI and coronary heart disease-related deaths. And what they found that there was no difference between hormone users and placebo after 4.1 years of follow-up with a hazard ratio of 0.99 and a strong confidence interval of 95%. And in a post-hoc analysis, coronary heart disease was actually increased in the first 8 months of hormone therapy, and therefore the recommendation that after acute coronary syndrome, women should not be on hormone therapy at least that first year. And this is the graph. The solid line is the estrogen-progestin women, and the dotted line is placebo. And as you can see, the hormone risk increases early on. And later on, the lines do seem to cross. And the question is there a later benefit? The conclusion, though, is that hormone therapy should not be used to reduce the risk of coronary heart disease events in women with coronary heart disease, and should not be used the first year after an acute coronary syndrome. This is looking at all types of outcomes. Coronary heart disease death and non-fatal MI showed no difference. Coronary heart disease death showed no difference. Non-fatal MI showed no difference. And coronary revascularization or unstable angina showed no statistically significant changes. So this brings us to the Women's Health Initiative studies. And it was actually 2 studies. One was released in 2002 and one in 2004. One was estrogen and progestin, and this is in a woman who has a uterus. And then the estrogen alone trial was in women who had had a hysterectomy. So these were women from 50 to 79, and there were over 10,000 women in the group who were on just estrogen only, and they had conjugated equine estrogen, or what we know as Premarin, 0.625 milligrams. And there was a placebo group in that arm. And then for women who had a uterus, they took Premarin, the 6.25, plus Provera 2.5, or medroxyprogesterone acetate. And there was a placebo arm there. And that group had over 16,000 women, so a large, robust study. There were multiple studies that came out of it, so if you feel like you're always hearing about the Women's Health Initiative, you are. There was the hormone therapy for coronary artery disease, but there was a calcium and vitamin D study. There was a dietary modifications trial, and an observational study of over 93,000 women were totally enrolled. So it's a very important study. So this is the data on the risk and benefits. And there were higher risk in the estrogen-progestin group, which is the yellow, for coronary heart disease, stroke, breast cancer, and venous thrombotic events. There was a slight benefit in the colorectal cancer and hip fracture group, and we tend to hear about that a lot from the gynecologist, that hip fracture is very important, and it is. The stats for that are 50% of women who have a hip fracture are living in a nursing home or immobile within a year, and 25% are dead at the end of a year. So it is a very dangerous problem to have. And the neutral effects were seen on endometrial cancer and overall deaths. So in this study of over 16,000 women who took estrogen and progestin, there was 29% increased risk of coronary heart disease, death, coronary heart disease events, stroke 41%, pulmonary embolism 113%, and breast cancer 26%, while the benefits were 34% for both hip fracture and colorectal cancer. And this study was stopped early. I'm sure you all remember July 2002. I'll never forget it because the phone starts ringing off the walls with all these women who said, Dr. Lundberg, you told me hormones were good for my heart. And we had to step back and rethink this. It was a crazy summer that year. So this study was stopped 3.3 years early because there was no benefit. And then the estrogen-only arm came out about 2 years later. It was over 10,000 women. And again, the stroke risk was significant, increased 39%. Hip fractures was a beneficial of 39%. But what did not seem to reach statistical significance was coronary heart disease, pulmonary embolism, breast cancer, colorectal cancer, total mortality, and their global index was 1.01. So overall, it was mostly a null study that hormone therapy did not benefit you, and the risk was mostly in stroke. And interestingly, dementia increased 49% after age 65. So there's been some talks that maybe hormones help your brain and help you prevent dementia. So how does this break down to your clinical practice? So when you're talking to a woman about taking hormones, if there's 10,000 women in your practice and you recommended estrogen plus progestin, 7 more cases of heart disease, 8 more cases of breast cancer, 8 more strokes, and 18 more patients with blood clots. So most people feel that this is a fairly low risk. And for women taking estrogen only, it's 12 more strokes, 6 more patients with blood clots, and no increased risk of breast cancer or heart disease. People have analyzed this data again and again, and what they have seen that is if you take the hormones within the first 10 years of menopause, there does seem to be a slight benefit and no risk. But from 10 to 19 years, there's increased risk with a increased risk of 22%, and over 20 years, that's when we really see women, the 75-year-old, the 80-year-old, has an increased risk of 71%. So we really don't want these older women still on their hormones. Well, what about newer studies that evaluate hormone therapy earlier in a woman's menopausal stage? So first is the KEEPS trial, and it really looked at, is there an importance to the timing? Is there an optimal time? So the Chronos Early Estrogen Prevention Study, or KEEPS, compared a different type of hormone therapy with an earlier treatment group. So it looked at oral versus transdermal estrogen and also had a placebo group. And it looked at progression of atherosclerosis as measured by carotid intimal media thickness and coronary artery calcium scoring. And it's looking to see, is there an important timing? Is atherosclerosis the problem? Once it's in the arteries, is that why hormones don't respond properly, or do we need to start early? And so it's looking at the timing. And it also predicted that hormone therapy would not be beneficial in older women, which is what we had already seen. There were 727 women, and they were aged 42 to 59 with the mean age of 52, so right within 1 year of the average onset of menopause for most women in America, and they were all within 3 years of their final menstrual period. The study went on for 48 months, and it was a multi-center, double-blinded, placebo-controlled randomized trial. The treatment arms were a lower dose of conjugated equine estrogen at 0.45, not the 0.625. So it was a lower dose, and then there was transdermal estradiol, which was given in the Climera patch, and it was 50 micrograms per deciliter, and there was placebo. And what they saw when you compared it with I did what you told me not to. And when they compared the time over months, these are 12, 24, 36, and 48 months, and these are all 3 groups here together, the conjugated equine estrogen, lower dose, the transdermal patch green, and the placebo blue. And as you can see, there's really no difference anywhere in that 48-month time period. And when they compared the calcium score, they looked at all subjects who had had a increase, this is increase in their score. So estrogen, transdermal estrogen, and placebo slight increase from the calcium score. If you looked at people who had a baseline of 0, there was some mild increase. And if you looked at the group who had a baseline greater than 0, so they had presence of atherosclerosis, also no statistically significant change in their increase. They all increased. So the conclusion was that there were neutral effects on blood pressure and mainly favorable or neutral effects on the cardiovascular biomarkers. The lower dose of conjugated equine estrogen and the transdermal estrogen had no adverse effect on atherosclerosis progression, but there was also no benefit seen in the coronary artery calcium score group. So then there was the ELITE trial, which is the early versus late postmenopausal treatment with estradiol. And again, we're looking at the timing. So this study had 643 women. They were randomized by 2 timing groups. One was within 6 years of menopause and one was greater than 10 years since menopause. This group used oral 17-beta estradiol 1 milligram per day plus progesterone vaginal gel. So again, we're trying different methodologies of the estrogen. And estradiol is probably one of the most popular ones now because women don't want to take conjugated equine estrogen. So there was 5 years of follow-up, and again, they did a CIMT at baseline and every 6 months, and there was a calcium score at baseline and final. And the CIMT had less progression with hormone therapy in the early timing group with the oral estradiol, but again, there was no significant change in the coronary artery calcium score in either group. And this makes sense because it takes time for the atherosclerotic plaque to calcify. You're not going to see a lot of change maybe in 2, 3, 4, 5 years. And then there's the MESA study, which we all know is part of what gives us our score on the calcium score for your percentile of risk. And it had an early postmenopausal hormone therapy arm as well. And the MESA study has over 6,000 patients in it. They're from 6 ethnic communities. And the study's been going on since, I believe, 2002. This is just a poster presentation, so you cannot read the study. It was, Medscape did a write-up on it this summer. But there were 1,358 asymptomatic women, ages 45 to 84. There was 12 years of follow-up. They had a calcium score at baseline and then every 2 to 4 years. The average age in this group is 63, so again, it's about 11, 12 years past the time of menopause. It has a nice breakdown, though. 20% of the women were 45 to 54, so the younger group. 36% 55 to 64, and then we have about half the group again over 65, so 31% in the 65 to 74-year-old group, and 13% over the 75-year group. So this is the group we really don't even want on hormones. It was nicely dispersed through different ethnicities, with only 49% being white, 25% black, and 18% Hispanic. And in this group, the average LDL was 114, so not that high. At the start, 43% had a calcium score greater than 0 with a mean Agatston score of 77, and there was a delay of hormones was associated with increased calcium score. So starting hormones later, this reinforced, is not beneficial. And then there's the SMART study, the Selective Estrogens Menopause and Response Therapy. And this uses serine estrogen receptor modulators, and it's a combination pill of conjugated estrogen with bazodoxifene, and the brand name is called Duavi, and I haven't seen a patient on it yet, so it has to be very new. This is a pooled analysis of 3 randomized, double-blinded, placebo-controlled studies, and there were over 2,700 women in the study, and they all have an intact uterus, and there was 2 doses, a lower dose of conjugated estrogen and the higher dose of conjugated estrogen. And in both groups, there was 20 milligrams of the bazodoxifene. And at 12 months, both doses showed improved LDL and HDL, but elevated triglycerides, which is consistent with what we see with estrogen, oral estrogen. And there's no outcomes on that study yet. So the North American Menopause Society is the largest organization of obstetric and gynecologists, family practice, and internal medicine doctors who deal with menopausal patients. And they put out a statement in 2012, and they've said repeatedly that hormone Therapy formulation, the route of administration, and the timing of initiation produces different effects in women. So this is a very individualized process. You have to discuss with this woman what she's going to take and how it's going to affect her overall cardiovascular risk. It's essential to start these women early if they're going to be on it. The absolute risk in healthy women, particularly in their 50s, are low, and it does seem to have no harm up to age 59. Long-term use is more concerning. Several studies have showed that if you use it less than 5 years, if you're using estrogen and progestin, that it's safer, but beyond that, you have increased risk of cardiovascular events, thromboembolic events, and cancer. And then the breast cancer risk increases beyond 3 to 5 years if you're using combination therapy. And it can be considered for longer duration in use in a woman who has a very low risk profile. So there are some non-hormonal prescription options for women to use, and antidepressants are really very effective. A lot of women do well with the fluoxetine, the paroxetine, the citalopram, escitalopram. For women who have a lot of pain, a lot of fatigue, gabapentin and even pregabalin is good. And then the hot flashes really do respond to clonidine. The problem with it, as we know, is dry mouth and feeling sluggish and tired. But a woman who just has hot flashes at night, 0.1 milligram of clonidine at bed will help her fall asleep and reduce her hot flashes. And then there's been several studies looking at all of these lifestyle things to help menopause, hot flashes particularly. Sleep seems to be the number 2, and then just the fatigue, moody. And a lot of these studies have no improved outcomes, but some women do seem to think they help. So we always recommend a healthy diet and exercise, avoid hot flash triggers, caffeine, wine, all the fun things in life. And then, women need to try to stay cool, layer, take off jackets, these things. Relaxation techniques such as yoga have shown some benefit in small studies. And then women like to take vitamins, supplements, herbs. None of these have really been that helpful. Chinese medicine and acupuncture may be helpful. And then topical progesterone, there's a yam cream that women buy that they rub all over themselves in melatonin. But again, in studies, none of these showed to be very beneficial. So one of my favorite things in medicine these days is social media and apps to improve patient outcome. And this is a really helpful app. It's free. You guys can all download it. And it's the NAMS app for going through a stepwise process with a woman about should she be taking hormones. And as you can see, there's a button for the healthcare provider and the woman. And what I love about it is I can go through it with her, and it's her age, her sex, obviously she's female, her ethnicity, her cholesterol, her blood pressure, and then in the end, you can email her the printout. So you're not the evil bad person not giving her the hormones that are going to improve her life. You're just going through it very methodically, and then she can get this information sent to her. So it really kind of takes us out of the role as the bad guys. It does look at diabetes as a higher risk marker for cardiovascular disease, just like all the cardiology literature does. It's actually quite compatible with what we do in our practices, and it actually gives the woman an ASCVD risk calculation as well. It also takes into account obesity because women have higher risk of DVT, venous thrombosis, higher CRP, higher PI, more risk with metabolic syndrome, insulin resistance, and eventually becoming diabetic. So it's very sound medical information. And then there's just some absolute contraindications with hormone therapy. A woman who's had an estrogen-sensitive cancer, such as breast tumor, should never take hormones. If she's had recurrent venous thrombosis or a serious venous thrombosis with massive pulmonary embolus. It's contraindicated with liver disorders and clotting disorders. It's contraindicated with previous heart disease, stroke, or TIA. Don't forget TIA counts. If a woman's blood pressure is not controlled, she should not start hormones until it is controlled. And then oral estrogen gives women problems with their gallbladders and increases their triglycerides, but we don't see this in the transdermal method. So we all know the ACC guidelines. They haven't been updated since 2011 and hopefully they will soon, but these are the recommendations for prevention of cardiovascular disease in women. And this is why it's so important to take a pregnancy history when you meet with these women, because previous gestational diabetes, previous hypertension with pregnancy, eclampsia, preeclampsia, preterm delivery, or a baby over 9 pounds all increase her risk of cardiovascular disease long term. You obviously want to look for symptoms, depression. Depression may get a lot worse during menopause. You want to go ahead and make sure she's not already obese or having problems with her blood pressure. And you want to make sure her lipids have been checked, because her triglycerides could really go up. And then you want this global risk assessment. And of course, known cardiovascular disease puts a woman in a high risk category. Do keep in mind diabetes and chronic kidney disease, and then the ASCVD risk score greater than 10%. And then women at risk, smoking and hormones is a really bad idea. So I really encourage these women to get off or look for something else like an IUD or some of these lifestyle things for their menopausal symptoms. Blood pressure, cholesterol, obesity, poor diet, physical inactivity, and family history of premature coronary vascular disease. And then metabolic syndrome, women who already have a really high calcium score on a CAC test, anything over 400, I'd be very hesitant to put them on hormones. And then don't forget things like lupus. These women are at higher risk for cardiovascular disease, but they're also at higher risk for clotting disorders, and so that's a problem with the hormones. And then again, the previous pregnancy history. And in the 2011 guidelines, it specifically says that hormone therapy or using SERMs are not used for primary or secondary prevention, and we are still sticking to that. So what's new since 2011? Well, first of all, this ASCVD risk calculator. I also keep that app on my phone and go through it with the patient and show them the risk, because even though a lot of times their immediate risk isn't that high, their lifetime risk can be 30, 40, 50%, and so it's a real opportunity to change that long term by trying to get them to improve their blood pressure or their cholesterol. This is a really nice review of heart disease in women. This just came out in Circulation Research this year, 2016, and it goes through our traditional risk factors, which of course are diabetes, smoking, obesity, physical inactivity, hypertension, and dyslipidemia, but also points out the newer risk factors: preterm delivery, hypertensive disorder during pregnancy, gestational diabetes, autoimmune disease, breast cancer treatment, and depression. So let's get back to our case. So just to remind you, this is a 52-year-old woman. She has abnormal lipids, high blood pressure, impaired fasting glucose, needs to lose weight, but has not in over a year, sees the gynecologist, has lots of menopausal symptoms, and is begging you for hormones. And this is a review of her data. I think you all still remember it from a few minutes ago. So according to the guidelines I've walked you through, she's definitely at risk per the women's guidelines. She has impaired fasting glucose and elevated hemoglobin A1C, and has 4 out of 5 criteria for metabolic syndrome. Her BMI is over 30, so she's obese. She has hypertension. She has an elevated LDL. She has a low HDL, and her triglycerides at the upper limits of normal, so it's not great. And she definitely has a high lifetime risk for cardiovascular disease. So, hormone therapy may worsen her blood pressure. Hormone therapy may benefit her low HDL and her high LDL, but it may worsen her triglycerides. And it may improve her insulin resistance. So it's kind of 50-50 on the pros and the cons here. But you have to take into account her menopausal symptoms and her quality of life. So what I would recommend if I was seeing this patient is, first of all, she go on a DASH diet, low sodium, high fruits and veggies, lean protein diet to help her lose weight, that she follow a low sodium diet to help improve her blood pressure, and that she get a routine exercise program and hopefully lose weight. And this should also help her hot flashes. It's going to help her BMI, her hypertension, her prediabetes, and her lipids. By adding a hypertension medication, preferably an ACE or an ARB, until her blood pressure is under control with lifestyle changes, is a good possibility, a good recommendation. I would reevaluate her lipids in 3 to 6 months, because I don't think she's really done much with diet or exercise to improve them. But we could consider a moderate intensity statin on her because her lifetime risk is high. I would also recommend she follow up with a primary care doctor that's not a gynecologist, either an internal medicine physician or maybe even an endocrinologist, because she is definitely heading toward diabetes and has 4 out of 5 risk factors for metabolic syndrome. And then if she really needed it, and I would recommend she try a few months of these lifestyle changes, she could use low-dose oral conjugated equine estrogen, low-dose estradiol, or a transdermal estrogen patch. And because she still has a uterus, she would need medroxyprogesterone. And these may be non-harmful until age 59. And the little mantra that I say over and over again, and the gynecologists say it too, is you want the lowest dose for the shortest amount of time to control the symptoms, but it's never to prevent cardiovascular disease. So this MenoPro app, what also I went through with this patient, suggested first that she try 3 months of behavioral and lifestyle modifications. And then it determines that her ASCVD risk score is 2.9, which we looked at. And so they said she could take a combination estrogen and progestin or the new drug for less than 5 years. And because she's on combination therapy, more than 5 years could increase her risk of breast cancer. And then they also went on to recommend lifestyle changes for the metabolic syndrome. So I feel like the MenoPro app is very in line with what we do from the AHA and ACC guidelines. So, what is the take-home message here? Well, observational studies showed us that hormones were good for women back in the 1980s and 1990s. But as we advanced to randomized controlled trials, we saw that for primary and secondary prevention, there really was no benefit, and there was concern of harm, particularly in older women. Now, some of the newer studies, KEEPS and ELITE, MESA, and SMART suggest that maybe starting at early and lower doses, newer, more modern formulas, may have some benefit, but suggest that there's really not a lot of harm. And then what we really need is upcoming research on what is best for these women, so how we can achieve improved cardiovascular benefits, improve vasodilatation, improve endothelial function without causing increased outcomes. And it really was the experimental studies have shown that HDL increase in vasodilatation happen with hormones, and that lowering LDL, insulin resistance, lipid peroxidation, intravascular collagen, and vascular smooth muscle proliferation, lowering all those things would be good for cardiovascular disease. So there's still some, goal that maybe hormones will turn out to be okay in women. So what is known is after the onset of menopause, women experienced increased cardiovascular disease risk. Menopausal hormone therapy in older menopausal women did not find benefit, and women receiving menopausal hormone therapy closer to the age of menopause may have a lower rate of cardiovascular disease. The duration of use is quite important. With estrogen therapy, there's potential coronary artery disease and coronary heart disease benefits with early use. And with estrogen alone, you don't have to be as worried about the breast cancer risk long term. You have an initial increase in coronary heart disease risk when estrogen progesterone is initiated further from menopause. So I really recommend that those 75, 80-year-old women be off of this. And there's an increased risk if the estrogen progestin therapy is continued more than 5 years. This is primarily in breast cancer. There's a lot of women who, so currently the recommendations say you want to be getting off at 65, and then there was a lot of women who just stopped, went cold turkey at age 65. The North American Menopause Society has come back and said that there's no reason to terminate it just because a woman's 65, but she should definitely be weaning with the goal of coming off. And so for some women, they're still having hot flashes up into their 80s. These women want to wean off much slower. The lipoprotein changes are real. Lipids definitely show improvement with hormones in their HDL, in their LDL, and Lp(a). And the triglycerides may get worse with hormone therapy, so you want to think about a transdermal patch or vaginal cream in those women. So hormone therapy is currently not recommended for prevention in women at any age, primary or secondary, and we'll just have to wait and see what happens in younger women. And that's it. Any questions or comments?
Thanks, Gina. That was fantastic. If you could give us an idea of your approach in the office, a lot of times it's going to be that the patient has symptoms that they're concerned about. They may not necessarily have major risk, but it's their symptoms and decisions around this therapy, and how do you take what you presented in 45 minutes here into a 15-minute consult, or what approaches do you use in your office as far as use of other office personnel? You showed the app. Can you give us an idea of how you think we ought to be approaching this type of situation?
So you're not going to solve this in one visit with a patient. You're going to have to see her back in a few months. There's going to be some follow-up. I always start with the opportunity to improve lifestyle, because pretty much all American women and 2/3 of women in this state are overweight or obese, not exercising. Less than 10% of women exercise. Something like 3% of women are ideal for all the risk factors. And they really do get some improvement with hot flashes, moodiness, sleep, even that, multitasking, focusing, if they start exercising. So I really try to get them to do that for 3 months and say, come back and then we'll talk about it. If a woman's in her really premenopausal stage, like, she's 46, 48, she's still having periods, but they're coming more irregular, I'm a little less worried about her staying on birth control, which is for a lot of women the first phase of hormone replacement therapy. But you're not going to be able to do this in one meeting. Using a nurse practitioner or advanced practice provider is great in these situations, because they can see them back at the 3-month follow-up, see how things went, see what their lipids are doing, if they're losing weight, those types of things. And you definitely have to work with the gynecologist on this too. Most of the gynecologists that I deal with, and I'm up at St. Joe's in Northside, and then with Emory at our new women's center at St. Joe's, they're very on board with these guidelines. There's very few of them out there still telling women, yeah, this is great for you, you want to stay on this forever. I really don't come across that. So, and a lot of times I'll see an older woman who's still on hormones, and I'll say, you've got to get off of these, we got to start weaning down, I want you to remind your gynecologist, blah, blah, blah. And they come back and they're like, oh, you were right, she was concerned, we started cutting back. So you're not going to solve it in one visit. Do have them follow up with your advanced practice provider, and definitely keep the gynecologist in the loop. And a lot of these women never give up their gynecologist. They're 85 years old and they're still seeing their gynecologist. That's an important relationship to these women. And you also don't want to appear to be at odds with the gynecologist. You want to be on the same team. Does that help?
Anyway, Gina, that's great. This is not meant as a hostile question at all.
But
So it is. So estrogen has very little to do with preventing or causing heart disease. That's sort of my take-home message. Is the focus on estrogen by some people, I guess mainly gynecologists, does that interfere with cardiovascular risk prevention? In other words, we've got a lot of things that do prevent cardiovascular disease, right? And yet, as you make the point, hormone replacement therapy is not one of them. So among men, we don't have to focus on that. We just can focus on blood pressure, lipids, all these things. So do women get shortchanged by some physicians from still a concern about estrogen and progestin?
Well, Spencer, what you say about estrogen being the lesser of the two evils is absolutely correct, but not that many women have had a hysterectomy that can just take estrogen only. So that's the other problem, is if you have an intact uterus, you have to have progestin in some form, whether it's 7 days a month or a low dose continuously, and then you can work out those formulations with your doctor. But I would, once you have a uterus, you're stuck with that combination therapy, and there is more risk there. And then a lot of women, they're having abnormal bleeding or this or that. They're like, oh, I should just have a hysterectomy. Well, I definitely advise women against that, because the problem with the hysterectomy is the next thing you know, they have incontinence. And women hate incontinence. So you want to keep your uterus. It helps with your pelvic support structures. If you have a uterus, you have to take progestin, and if you don't, you're one of those lucky women who could take the estrogen alone, and apparently can take it as long as they want. But that's less than 10% of the population, maybe less than 5%.
The rest of my question is more philosophical. And I know we're getting away from this 10-year risk of cardiovascular disease and talking about lifetime risk. But it occurs to me that the lifetime risk of dying is 100%. And if you got something, the lifetime risk of cardiovascular is like 35%, I mean, that's the leading cause of death. So how do we translate? I mean, if you have a woman with a 2% 10-year risk of something, I'm wondering what her 10-year risk of everything else is. It must be higher than that. So, I mean, we're looking at the elephant from the cardiology perspective, but there are a lot of other things. So I just wonder what you think about this lifetime risk. Because when you say it, it sounds like, oh, that's I got a 35% chance of having cardiovascular event. Well, yeah, right. And you got a 100% chance of dying.
Well, if you don't die from cardiovascular disease, you're going to die from cancer, an infection, or an injury, basically. So it's just sort of picking which way you want to go. And for most women, they're terrified of stroke. They're actually a lot more afraid of stroke and the disability that goes along with stroke than they are of a heart attack, because everybody has the idea that when they get to the hospital, we're going to stop the heart attack and everything's going to be okay. And they don't even take into consideration sudden cardiac death or arrhythmic death. So I think for most women, they don't want to be disabled, they don't want to have stroke, TIA, that type of thing. They're Alzheimer's. So they're much more motivated to reduce their cardiovascular risk. You can't necessarily change your risk of getting an infectious disease unless it's flu or pneumonia and you can get a shot, or cancer. You want to keep those risks low. And as the cardiovascular deaths are declining, the cancer risks are going up. And so that's a real thing too with the estrogen and progestin. If you're on combination therapy more than 5 years, you're going to increase your risk of cancer. And then you've got the blood clot risk. So it's not all safe with estrogen. And I think each woman has to sit with her doctor and individually discuss that. And if any of you doctors don't like having that discussion, you can send them to the Emory Women's Heart Center at Midtown or here or St. Joe's to see any of our excellent physicians to go over this. Thank you. Oh, Bob. Okay. Can't get away.
So two things. One, I'll sort of chime in with Spencer. At times it seems like when you're counseling someone that the hormone replacement therapy discussion is a distraction. Is that sort of what Spencer was getting to? It's an issue, but then we never get around to, like your patient with the weight loss and and lots of times no blood pressure, poor blood pressure control, et cetera. So, I do think that's sort of a problem, sort of a real practical problem, in that there's no benefit and maybe some help with some other symptoms, and then they just sort of forget everything else, which is what we know. I guess my other question is about the...
Can I give you my comment on that before
Sure.
I forget it?
Sure.
And again, just like I did, I think you have to bring it back to the lifestyle. That if you had 20 pounds off, you would feel better. If you had 20 pounds off, you would sleep better. If you were eating healthier and didn't have so much sugar in your diet, you might think clearer. So I think we can bring it back to lifestyle changes, because there is some promise that their menopausal symptoms are going to get better with it, and of course their cardiovascular risk profile is going to get better. So I just think we have to link them together. If we think of hot flashes and hormones as the only options, then we're losing the game in our strategy. We have to remember that hot flashes do respond to weight loss, exercise, healthy diet, cold water, a lot of beneficial things that'll improve their cardiovascular risk as well.
So that leads into my second question. So then the other pushback I get from patients then for discontinuing is the hip fracture thing, which you talked about. And then the other is the dementia thing. So not even sure on how good those data are about cognitive function, long-term cognitive function, and hormone replacement therapy.
Well, the hormone replacement therapy data on Alzheimer's is definitely iffy, but just this week a study came out showing by improving blood pressure, you reduce dementia and Alzheimer's. So again, it comes back to those cardiovascular risk factors as our primary focus. And then for the hip fracture, again, exercise, healthy diet, high dietary calcium seems to improve that as well. And then if a woman needs something for her bones, there's other options besides hormones. So I think almost any benefit we're looking for comes back to cardiovascular lifestyle and behaviors as our first line, and medications as our second line. But the other thing is these women need to hear at 40, from 40 to 60, they need to be hearing exercise, lose weight, stay healthy, so that when they're 65, they don't have the cardiovascular risk factors, and if they start the hormones in the perimenopausal years and at least continue them up to 59, there's probably nothing to be concerned about. Anyone else? Thank you very much.
The preceding program is copyrighted by Emory University.